Hi, good afternoon, everyone. So I'll be speaking on SBRT in early stage non-small cell lung cancer. SBRT is the alternative treatment option for the early stage lung cancer who are not fit or who are not willing for surgery. So what is SBRT? SBRT is just a method of external beam radiation therapy. It is very accurate and precise as compared to conventional radiation therapy. We can deliver a high doses of radiation therapy in one or few treatment session, and it usually delivers in the extracranial target as compared to stereotactic radiosurgery, which usually delivers to the cranial or the brain metastasis. So what are the indications of SBRT? As Dr. Virendra has already mentioned, the T1 to T2 node negative comes in the bracket of the early stage lung cancer, and for SBRT we usually consider the node negative patient for SBRT. The usual candidates are medically inoperable, those who are deemed unfit for the surgical resection, or the patient not willing for surgery in early stage non-small cell lung cancer are the usual selection candidates for the SBRT. So what is the evidence for SBRT as compared to conventional EBRT? There are two randomized controlled trials, the SPACE and CHISEL, which have shown that if you deliver SBRT as compared to conventional EBRT, the disease-free survival as well as overall survival is much better if we can deliver the SBRT for early stage as compared to conventional EBRT. And what is the evidence for SBRT as compared to surgery? There is no level 1 evidence, but there were many attempts to just compare the surgery versus the SBRT. So this is the pooled analysis of approximately 55 patients from STARS and ROSEL. One is the US trial and one is the Netherlands trial. And in only 55 patients that has been randomized, they have shown that the overall survival in surgery was approximately 80% and 95% in the SABRE arm. However, there was certain criticism of the surgical treatment that has happened in both the trial, and we'll not go into the detail because there is no level 1 evidence for the SBRT as compared to surgery. But what the US or the MD Anderson group has done is that they continue to have the prospective single arm trial, so which they label as revised STARS, and they extended the SBRT cohort and they compared with the pre-specified published institutional surgical cohort. They accrued approximately 80 patients and they have shown that the 5-year overall survival is close to 87%, which is which usually matches with the overall survival of the surgical cohort. And on the propensity score matching analysis from the same institute, they have shown that SBRT is approximately 87% of 5-year overall survival versus 72%, but this is a non-randomized comparison we need to keep in mind. So these are the ongoing studies, and so the Valor is almost in conclusion. They have completed the accrual more or less. Stable Meds is accruing, and the Saber Tooth from the NHS, they have just concluded that they were not able to do a randomized control trial. But the important finding from the Saber Tooth, that is the NHS trial, is that many of the patients who were randomized to the surgical arm, they preferred the non-surgical treatment, and that's why they were not able to do the randomization between the surgery and the SBRT group. So that's why they have to close the trial prematurely. So how we do SBRT in early stage non-small cell lung cancer? There are 5 main important criteria to just look at it. First one is the total dose. The second is the dose per fraction. Third one is the location. Fourth, we will discuss about the result, and fifth, a slight bit about the complication. So we need to deliver a biologically effective dose of more than 100 Gray. So which has been shown in the paper by the Onishi et al. From Japan, that the local recurrence is much less if you deliver approximately more than 100 Gray biologically effective dose, and the 5-year overall survival in that particular paper was approximately 65%. So the survival and local control improves as we increase the BED. So BED is very important when you want to deliver the radical or ablative doses for early stage lung cancer. However, there is a certain characteristic called no-fly zone. Here we call it as the no-fly zone based on the Robert Timmerman paper, which have shown that whenever you deliver the high dose radiation therapy in 2 centimeter around the proximal bronchial tree, it might be hazardous for the patient. It can lead to 11 times more risk with the central tumor as compared to peripheral tumor, and there can be treatment related death also. The freedom from severe toxicity at 2 years was much higher in the central tumor as compared to peripheral. But can we just not do radiation therapy in this no-fly zone? No. So we can do the risk-adapted SBRT depending on the location and the size. For the T1 tumor that is less than 3 centimeter, we can deliver up to 20 gray in 3 fraction. And on T2, they have done 12 gray in 5 fraction. This is the Netherlands paper. And for tumor adjacent to the hilus, mediastinum or heart, that is the proximal bronchial tree, they have reduced the dose per fraction from 20 gray to 7.5 gray to avoid the toxicity. And what they have shown is that there is no grade 4 or 5 toxicity encounter. So this is the first RTOG 0236 trial, prospective trial, which have established SBRT for medically inoperable patient, and they have shown that the 3-year and 5-year overall survival can reach up to 55 and 40%. So this is the Japanese trial. They are more advanced as compared to SBRT technology as well as the results. They have published their long-term results. Say for example, 10-year overall survival is 24%. That means 1 out of 4 patients who was treated with SBRT is surviving for 10 years. And the 10-year local control was also excellent, close to 85%. But what about the central lung tumor? Because so many of the tumor which we will get the referral from the surgical side will have the central lung component. So this is the no-fly zone, but in 2010, Dr. Bezak et al. From RTOG 0813, they have included more tumor touching the mediastinal or the pericardial pleura, and in 2015, Chang et al. Also included the tumor close to the brachial plexus and the heart. And they have shown that the central lung SBRT can be done according to the lung trend trial, which have adopted the 7.5 gray into 8 fraction, which is very less as compared to 20 gray per fraction. And they have shown that the acute and late grade 3 or more toxicity is acceptable within a range of 7% and 20% respectively. We also get the referral for the ultracentral tumor. What do you mean by ultracentral tumor? The ultracentral tumor, whenever the tumor is abutting the critical structure, say for example the proximal bronchial tree, the main bronchus, or the pulmonary artery, or any major vessel, the outcomes are poor compared to the central or the peripheral tumors. The ultracentral are at a higher risk of a treatment related to morbidity as well as the mortality. So this is the HILUS trial, which is a very important trial as far as the treatment related morbidity is concerned. As you can see here, there are 2 groups of patients, those who are less than 1 centimeter from the PBT and those who are more than 1 centimeter from the PBT. The authors have shown that whenever you treat a patient which are less than 1 centimeter from the PBT to a high dose, you can have at least 10 treatment related death out of 65 patients. That means at least 20% patients have a treatment related mortality. So we need to be very careful whenever we are dealing with ultracentral lung tumors. So this is an example that we have recently treated the ultracentral SBRT. The tumor was very close to the right main bronchus. So we need to be careful as far as the dose per fractionation is concerned. So now coming to the merger of the immunotherapy also as well as chemotherapy as compared to the SBRT alone. So this is the paper by Chang et al. From MD Anderson, which was published in Lancet. They have combined the immunotherapy as well as the SBRT, and it's an open label randomized phase 2 trial. What they have shown is that after a median follow-up of 33 months, that the 4-year event-free survival was much better whenever you combine the immunotherapy and SBRT as compared to SBRT alone. And none of these patients had grade 3 or the worst toxicity with SBRT. And the immunotherapy used was the nivolumab 480 mg on first day of RT or within 36 hours of the SBRT. So this is the combination of the SBRT plus the immunotherapy. So in the COVID era, there were patients who were having the SBRT wherever the patient is waiting for the surgery. So they have given the SBRT prior to the surgery, and then they deliver the surgical recession. And what they have shown is that the pathological complete response is achieved in approximately 60% of the patient. Apart from that, there are other studies which are combining the immunotherapy and the SBRT. This is the neoadjuvant durvalumab with or without SBRT in patients with early stage non-small cell lung cancer. It's a single center randomized phase 2 trial. As you can see here from the red graph or the waterfall plot, so the major pathological response whenever you combine immunotherapy plus SBRT is much higher as compared to SBRT alone. So there's a lot of scope as compared to the high dose radiation therapy, SBRT, and the immunotherapy. And so this is the post SBRT evaluation. I am just trying to show this because a lot of our medical oncology and surgical oncology colleagues are very worried about the post radiation changes in SBRT. But if the tumor size is less than 3 centimeters, there are usually not much major changes that is happening in the lung, and the pulmonary function test parameter will be more or less close to the baseline value. So with this, I would like to thank you for the patient hearing.
For this session, welcoming any questions, if there are any, for any of the speakers. Yes, sir. Yeah.
Dear Dr. Anil, nice to hear excellent clarification from a colleague on surgical side. You being a guidelines defining institute in India, a stage T1, a peripheral 2 centimeter tumor fit for SBRT, fit for surgery, the surgeon sees it before surgery. Do you see it before he operates?
Yes, so we see all the patient in multidisciplinary tumor board.
What do you say at that time to the patient?
See, as far as the evidence is concerned, because we believe in evidence.
Yes.
So, as you have already mentioned that we are evidence generating or have a guideline generating institute, we do believe in evidence, and as far as the evidence is concerned, I do not have the evidence to say that the SBRT is superior to surgery as far as till date is concerned. So we will go ahead with the surgical evaluation, and if the patient is not fit or is not willing for surgery, so definitely we'll give you an option of SBRT if the patient is not willing for surgery.
Again, going back, you are going to give the evidence when you are going to do the trial.
Yes. No, we won't be able to do the trial, sir. So because a lot of countries have already tried and attempted to do SBRT versus surgery in early stage non-small cell lung cancer. The first thing is that we usually see approximately 2,500 patients of lung cancer in an year.
Phenomenal.
But the point is, our thoracic surgery colleagues do operate only 50 to 60 patients in a year. And out of that, early stage T1 or T2, or say for example T1, it will be hardly 5 or 6 in a year. It's practically impossible to conduct a randomized control trial in India.
Thank you. Yeah. I understood it. Thank you.
Dr. Virendra, you want to add something?
Yeah, yes. So in central tumors, which you have shown, what are the motion management strategies you are taking care of it?
So motion management strategies is a blanket term. We usually do at Tata Memorial Hospital is the 4-dimensional computed tomography, which is like a motion encompassing technique. People have a lot of other motion management strategies like the DIPS, or you can have the CyberKnife or any the real-time tumor tracking, but we do the 4-dimensional CT scan.
Another thing, in the era of immunotherapy, when we are combining the phase 2 trials, there are some hypotheses that we will try to put like large vessels as OAR to reduce the lymphopenia. What's your take on that?
So there is an evidence for the stage 3 non-small cell lung cancer, because in stage 3 non-small cell lung cancer the volume is pretty large and there is a lot of bone marrow which will be irradiating, and that can lead to lymphopenia. So the lymphopenia is itself a poor prognostic factor, but in SBRT it's usually the central tumors are there, but the radiation therapy to the bone marrow is pretty zero. It's practically zero. So there is no concept of lymphopenia in SBRT patient, unless until it is close to the vertebral body.
Sir, adding to this, any biomarker you are using during the treatment of SBRT? Basically, I wanted to ask about lymphocyte assay.
No, we are not currently doing it.
Is there any trials are going on?
As far as my knowledge is concerned, no. For SBRT, no.
Okay.
Can I just ask Dr. Virendra Tiwari one question? Given the results of the Checkmate 816 trial, what do you see as the possible role of mediastinal lymph node evaluation in the near future?
With immunotherapy coming in a good way, these things will have lesser role in future, because response rate is good. With Checkmate 816, the PCR rate was what I'm not very sure, but more than 20%, I think, PCR rate. So there is a good response. So with chemotherapy, we were thinking that response will be only at the node, but with immunotherapy, there is a good response at the node as well as primary. So role of invasive staging will further go down. It will be mostly based upon the imaging, and then take a call on that, because immunotherapy followed by surgery will come is actually coming in a big way.
Right, thank you. Dr. Yadav, sir, about lung cancer screening. I think what is the practical method of implementing this? I mean, do we have to have a surveillance program? I mean, we can't really possibly have a screening program here, no?
Yes, sir. So basically, we have many challenges to implement that. A country like us, like Nepal, India, is very hard because of cost factor and availability of services. City services are not there in every sector of every part of the country. So that are the challenges. We cannot implement that thing, but it will take time if government or from government side only they can start, or then only possible. Otherwise, it's very difficult.
Yeah,
Sir,
maybe.
sir, can I add on to that, sir? Sir, can I add on to that?
Yes, yes.
So one of the things what he said is that it's difficult for us to do because of the cost. So one thing what we really encourage to people is, one is opportunistic screening. For those patients who come for other things, we at least counsel them regarding that. And a lot of corporate hospitals in Bombay are trying to get it included in the health packages. Though the only problem comes to the insurance companies. If you're a smoker, you fit the criteria, and the minute you fit the criteria, you will not get further insurance. So that is becoming a vicious cycle.
Actually, it's not only the cost, because there are several groups in India who are actually willing to do an LDCT for 1,000 rupees,
Yeah, but
which I don't really think is very much.
the patient is a smoker.
The problem is that when you actually find some lesions,
Exactly. And if you're
then
a smoker,
who pays for that?
if you're a smoker, you don't get covered on the insurance scheme. The minute you mention it, you are a smoker, you have to declare. And the minute you declare you're a smoker, your insurance, most of the companies back out. So that is a problem till there's a level at the change where the smoking is included, like in other countries, US, and then till then it's difficult.
Right, thank you.
Sir, just one suggestion. I think because most of our population is below poverty line, and government has done very good by covering them under Ayushman. So I think we can, as a general oncology community, the surgeon, radiation and medical oncologists, we should push government to include screening, like especially for lung cancer, in the scheme itself. So by that time, most of the people from rural village or even in urban center can go through that.
So I don't think sort of it's a very practical solution, frankly, because although the government has introduced Ayushman, the vast majority of services are actually being provided by the private sector in India today, and many private institutions are unwilling to actually take Ayushman as given. And further, I think when you introduce screening services, you are actually introducing a competition for the people who actually already have diagnosed conditions and not given timely or adequate treatment. So I think by putting in the screening program into the Ayushman program, you're actually going to confuse issues. And I think the solution is far more difficult than what it appears to be. Thank you.
Sir, one question last. Sir, what's your take on flash RT if in early stage lung cancer?
I don't have any experience with flash RT. It's just currently it's available in US. We do not have any experience in flash RT.
I thank Dr. Bal sir and Dr. Anil for chairing this wonderful session.